Hello, namaste everyone. Namaste. My name is Dr. Rahul Karel. I am an emergency medicine physician at Brown University. I'm an assistant professor. We are here for the scientific session this afternoon. Thank you so much for joining. On the behalf of American Nepal Medical Foundation, I'm honored to welcome you here. Please keep your voices down and listen to these wonderful presentations that people have come from very far, from Nepal and within the USA to present their work. So we're gathering here today as clinicians, as researchers, as public health professionals, as well as maybe non-medical folks as well, to learn about some of the innovative work that some of our colleagues are doing. We know one thing, no matter how strong our passion is, evidence really matters. So to create that evidence and to understand evidence and then find solutions from that is a key. So this session is quite important for that. So I'm thrilled that our session will include not just data and outcomes, but some stories from the field. I'm privileged to have my co-moderators here. Along with myself, we have Dr. Pragya as well as Dr. Kiran. So I would like to ask Dr. Pragya to introduce yourself.
Thank you, Gaurav. I am Pragya Gaurav, professionally I'm an infectious disease physician practicing in Northeast Pennsylvania, and I am also a epidemiologist as well, and I'm honored to chair and moderate this session along with Dr. Karel and Dr. Sapota. As Dr. Karel mentioned, the goals and the aim of this session, I cannot emphasize more on why research is needed to enhance the work at the ground level, which can ultimately improve the healthcare of our citizens back in Nepal. And I'd like to thank all our visitors from Nepal and from here, from the USA, for coming and sharing your work. We are here to look forward to learn more and give back to Nepal as well as in our practice. And I also thank all of you for your time and your presentation and your work over here. Now I'd like to welcome Dr. Sapota for any questions.
Thank you, Dr. Pragya and Dr. Ramu, for allowing me to present here and co-host the session. I'm Kiran Sapota, and I'm an assistant professor at San Francisco State University in Houston, Texas. Before moving to academia, I was working at the health department. I was working specifically with infectious disease management during the COVID time, such as COVID-19, monkeypox outbreak, and other disease outbreak. After I left the health department, I took an audition at a university where I'm currently working. I checked my focus area for disease management. Mostly diabetes, cardiovascular disease, and cancer, and I have some good collaborative project in Nepal. So today, I'm very excited to have this presentation sessions here, which not only provide numbers, but the outcomes that have a very fruitful impact on our communities, possibly in Nepal and abroad. So without further ado, let us start our presentation session. Thank you so much.
Okay, thank you, Dr. Sakuda. So, I have the honor of starting introducing our first speaker. So, I have Dr. Divesh Vital from Nepal. He's a consultant in the hospital as an anesthesiologist. He has strong academic and clinical passion, palliative care, and cancer pain management. So, we will be sharing palliative care in Nepal. Let's welcome Dr. Vital.
Thank you so much. Good afternoon and namaste to you all. I would like to thank the organizing committee for this privilege to speak on this very esteemed stage. And for about the next 8 minutes, I'll be going to speak about palliative care and how this scenario challenges. I think it would not be an exaggeration if I say that foundation of palliative care has been making our back to many areas and our philosophies of order milestone and guidance for us to move forward and ask for care. And these are like government policies, like principles for our palliative care. And today is important day palliative care aligns with our traditional concept of medicine, salvation, liberation. And it has been a very buzzword about the discussion part about what is a good thing. And in our Vedic areas and in our Oriental philosophy, we always talk about subtlety. That means the very good death, that it's simply implies peaceful, spiritual, spiritual readiness, and we have taken our duties like peace. So, compassion, that means daya and the non-harming. Ahimsa is always an cornerstone of our palliative care philosophy. And palliative care, in a nutshell, we always consider as a sacred duty in context to our religious duties. So let's talk about some statistics. It is estimated that 2% of the passing palliative care, which is the research conducted in 2019, and in one group is a study conducted back by co-workers, my co-workers, and they found that 6.4% non-communicable disease, 3.0% in fact. And if we look into the burden of the disease and the traditional and the orthodox thinking in palliative care is all about cancer and the terminal effects or burden of disease, moving into the other arena of non-communicable disease and the like chronic kidney disease, respiratory diagnosis. These are clinical burden and mortalities of palliative care. And we have approached comprehensive approach, which is multi-level approach, and we have seen we have 4 pillars of the multi-level policy, pillars and if we look at our Nepal into the global perspective, it's all the levels, it means that there are generalized palliative care, but I think we should be moving down. It's decayed, that means it's fragmented, that means we have to work in order to improve ourselves. And these 4 pillars of the cancer is policy making, education, and drug availability and service. We have here that in Nepal we are working on these 4 areas to improve ourselves. And national strategy in 2015, we have our Magna Carta, that means Constitution. It has dictated us as a right, and we have every rights to have good health. And in 2019, health policy integrated palliative care into the national policy, and we have universal health coverage program, global program. We have as part of the universal health coverage program, we have palliative care. critical part. If we go back to the case into the services, well, formally a kind of modern palliative care starts back in 1990 when the oncology unit started palliative care, and this was the case that is in our traditional things it's a category. There are two pillars of having initiation of palliative care in Nepal. There are Hospice Nepal is doing a very wonderful job in catering palliative care in Nepal, and this being a remarkable job in actually palliative care coverage in Nepal. And one of the pillar of one of the foundation of palliative care Nepal is the education and capacity for which many organizations are working. Key role, the playmaker is here it is National Association of Palliative Care in Nepal, and this is also this organization is a key role member for providing advocacy, service, and education and capacity. Other organizations like and the large institutions teaching hospital like IAM and national partners that is also remarkable. These mentioned partners as major key role there because they have included curriculum in their part of the undergraduate and post-graduation training program as a part of it. And there are, of course, many barriers to tackle through it, but low access throughout the country because of the difficult terrain and topographical challenges we face and lack of awareness among medical as well as non-medical professionals. And we do admit that we have very short manpower who are currently working in this palliative care, and there are major factors. One of them is the availability of the body and also. And there are many models of innovation. There are many models which are practicing throughout the world, but this integrated care, that means that it should be integrated as a national health policy, and the national health program is the one of the successful model. And another is the community-based model that is widely accepted out of the Kerala model, where in Kerala in South India they have a very good community health workers. They have incorporated their community workers, and actually we also in Nepal is also incorporating the female community workers as a carrier of capturing palliative care in Nepal. And this palliative can be one of the good model of innovation right back in Nepal, and it would be a very good collaboration between the West Road and East Nepal. And this organ palliative integration is a very good model where physician and other specialty refer in the very early days. So to conclude my session, this palliative care definitely in Nepal blends with ancient values of Vedic, our philosophy and our policy here, and this modern strategy of adopting WH policy of palliative care in Nepal. Needless to say, at the last moment, policy, education, and innovation are essential for the progress of palliative care in Nepal. Thank you so much.
Hello. Thank you, Dr. Lida, for your excellent overview of the infrastructure of palliative care in Nepal. And it's, personally to me, it's really comforting to see that there's a lot of work going on in Nepal in palliative care, which I was not aware of. And that is an emerging field of medical sciences, which is not only in the US but much needed in Nepal. Does audience have any question? If there is none, then I have one which is probably to the bedside level. The topic of palliative care, even in the US, when I see patients from our community, it's hard to open the topic. How is it perceived by patients and family in Nepal?
Still, it's really backward for this Nepal talking because it's a delicate field talking about death and dying. It's also true in Nepal, especially the worrying fact in Nepal is pollution. It also means we as a physician and the caregivers, they try to hide everything from the patient. And they are very reluctant to open up and open the secret about the death and dying. So that's this collusion between caregiver and physician.
Thank you for highlighting that. It's not only in Nepal, but even out here, it's for patients out there. We have to learn the art of how to break the bad news or sad news and how to deal with it so that the patient does not suffer and gets involved in care. Okay, with that, I'd like to thank you for your excellent presentation, and I will ask Dr. Sarkoja to introduce our next presenter.
Thank you, Dr. Prokya. It's my pleasure to welcome our next presenter, Dr. Rajesh Pandey, and the topic of the presentation is Preventive and Screening Health Services for Children in Nepal. And a short bio. Dr. Rajesh Pandey is an associate professor of pediatrics at UT Southwestern in Dallas, Texas. He is deeply involved in medical education and health service implementation in Nepal. He serves as chair of the American Academy of Pediatrics Certified Maintenance of Certification course targeted to pediatricians in Nepal and the USA. I would like to invite Dr. Pandey for the presentation. Thank you. And I'm honored to this. I know the title is long, but the basic premise of that is the preventive and screening care in the children beyond Nepal. I'm presenting on behalf of the team. Dr. Bhagwan Koyal, I'm team from Kioch, and Dr. Vidasman Karmacharya and his team from Tulita Hospital. The basic premises is don't know our children, they got periodic and screening health services every so often. But in Nepal, me and a lot of people I know, we never want to see the doctor unless we are sick. And the problem is that there is lost opportunity for the early detection of the disease that leads to increased morbidity and also mortality. This is a busy slide. I don't want you to pay attention to that, but this is the AAP guideline and what are some of the things that they do in different stages to the pediatric office, starting even like prenatal counseling, starting shortly after birth, 2 months, 4 months, 6 months, a year, 15 months, 24 months, and every year after that. But that gives the opportunity for the doctors and the parents to catch the medical conditions sooner, so there is effective intervention to prevent the morbidities and mortalities. In Nepal, as we have heard this morning, there are more than 10 million children, and out of whom about 7.5 million go to school. So about 7.5 million school-age children in Nepal lack access to the periodic screening and preventive health care. Again, that leads to the increased opportunity for the missed opportunity for medical. The problem of nursing doctor side about the typo is there is a huge problem of pediatric condition, including the eye and vision problem, about half of the cost. About 5 to 6% of the students have some hearing problem, and majority of them are very close and easily treated.
malnutrition and obesity combined have about 35 to 40% prevalence in these children. The oral health challenges, including gingivitis and oral cavities, are quite common. Involved that affect more than 50% of the students. Mental health disorders, anxiety, depression, behavioral problems are quite common, and they are a big problem. The goal of this health study is to enhance access to the preventive health services screening, to study the prevalence of common childhood diseases, to promote health education and counseling, and manage everyone. So how to address the challenge? The school health program here will take out kids to the pediatrician, but it applies more than 10 million kids, children, and less than 1,000 pediatricians. So it's possible to get to the doctor's office. So rather than adopting the model from here, the effective model may be training the manpower who can do this school and the training program in school. Then there will be data collection and analysis of the record, and all the students who are screened at the school will be categorized as those with the normal screening and the abnormal screening. The findings of the screening will be communicated to the parents, and the students who need further assessment will be referred to the partner hospitals. So what is the relevance of the advantage of the student program involved? Again, the big problem is we don't have a system to take children to see the doctor, so taking the medical to the hospital is one of the big and it increases the access to the healthcare. It helps with the early detection, and also enhances the community involvement. What we want is benefit access to the healthcare, to understand the prevalence of the community condition. We also get the opportunity for the health education, health promotion, and we also want to evaluate the development. So some of the things like I might have I want to say some so far evaluated about 1,500 students, a population like 5 to 18 and 60% they have never seen the doctors. Prevalence of the common infected finding is again close to 40 to 50%. There is huge prevalence of the mental health condition, oral condition, and a lot of them can be easily corrected and treated, which leads to better health, better learning environment, and decrease the stigma of the students. With that, I welcome any questions that you may have.
Thank you, Dr. Pandey, for your presentation. And the floor is open for questions. If you have questions, please raise your hand so that I can come there and hand over the mic. Okay, I think, yeah, I'll look around, but I have two questions for you regarding the presentations and very wonderful work, possibly a new kind of work. So will you share if this is a pilot project, this is a research, or is it an implementation project? Like, has this begun, or this is in the initiation phase? Some background of it so that we can know how this has a program.
Great question. So it is one of the implementation. I don't think we need to show the effectiveness of the screening program. It is already established and it is common practice in most of the developed countries. But it is more of the health service implementation side. We have started, but still we have a lot of things to do, like creating the electronic medical record, data collection, and how to do the long-term longitudinal follow-up. We have done some feasibility studies because one of them is that we can't implement everything that we here in Nepal, so we are doing the IT processes, evaluating how the students and see how we can adopt or change the system to better capture the population moving forward. So as a part of that, we have done the feasibility study. We want to do close to 5,000 student feasibility, and we have already done 1,500 students.
So this kind of screening program and the data that generate will help the policy, right?
Exactly. The goal is to do the bigger level biometric study and advocating for the country to the policymaker that it is a cost saving, more than cost effective, because we believe that we don't want the like cost effective, but it actually saves the cost by this. For example, one example I want to use is that, like in Nepal, I cannot take a child to do all the things we can get done in the office. If a parent wants to do that, they have to take it to the medical officer for the physical exam, dentist for the eye exam, doctors for the eye hospital for the eye exams, mental health specialist for the screening of the anxiety and all the things. And it took 3 days, and that will cost on our estimation close to 2,500 to 3,000 rupees, $25 just to do all the things. And that doesn't capture the missed 4 days and the missed 2 days. Our initial estimate is that we can do the same thing at a school, something between $8 to $10 cost. So that already says about 60% of the cost, plus without any disturbance of the work of the parents, without missing work revenue, and without.
Great, thank you. Okay, we have one back with the last questions.
And ask how you are doing practical level.
Great question. The school health facilities.